Okay, hello everyone. It's a pleasure to have you, Mario Leitao from Memorial Sloan Kettering Cancer Center in New York to discuss something about the introduction of the molecular profiling in endometrial cancer figure staging. So the first question that I would like to ask to Mario is, are we ready to have the molecular profile assessed in endometrial cancer patient before surgery and then surgery accordingly?
Thank you for inviting me, Valentina, and hopefully this is helpful. So, I have to also start off by saying that we've been doing next-gen sequencing in IHC for our patients for many, many years. The TCGA data includes many of our cases in there. We were co-authors on that paper too. So we've been a very big proponent of learning more about this cancer. I think it's a little preliminary to start making clinical decisions using some of the molecular information we have yet. We're still refining our knowledge. So it's a long answer to say that we aren't ready to really assess molecular profile to determine what type of surgery to do. We don't do that at our institution.
Okay.
We don't do the molecular profiling on the biopsies. We wait for the final pathology and we do our MSK impact, and they all have IHC performed also.
Okay. So thank you. The other question is, you partially already responded, but is the immunohistochemistry surrogate for molecular profiling reliable? So can it be performed on a hysteroscopic biopsy before surgery, or do you think it's just a punch biopsy is not enough to characterize the whole tumor in that sense?
Yeah, there's some emerging data on that aspect. It does seem to correlate pretty well, an endometrial biopsy pattern with the final pattern, but it's not 100% either.
Okay.
So I think you just have to be a little careful. Just IHC in general is not perfect. Because if you actually do next-gen sequencing, you'll see that in true p53 mutations, the IHC is only correct maybe 90 to 95% of the time, so you'll have some non-correlations between actual next-gen sequencing information and the IHC. And for p53, that's been known forever. My early lab work as a fellow was on p53 and ovary cancer, and we looked at actual sequencing and p53 alterations, and it wasn't 100% concordance, so you have to be careful with that no matter when you do it. And obviously you can't do POLE in most places, and you might not have enough tumor for doing POLE currently in a biopsy. So I think if it's going to change what you're going to do, then okay, and it's somewhat correlative to final path, but we don't.
Okay. Thanks. So we know that in MSK, you, of course, just perform sentinel lymph nodes only formula. Is it still valid in the molecular profiling era in endometrial cancer?
Yeah, I think, my presentation, I'll go into more detail on this, but anatomic stage is still the most prognostic factor that we have in this disease. So node positivity, nodal metastasis is one of the greatest prognostic factors for endometrial cancer. So I don't think we should make the mistake of replacing good staging and the information we have for many years with this new fancy or new shiny tool of molecular classification. I think it needs to be done together, and we build on our knowledge of endometrial cancer by starting with the anatomic stage, starting with properly staged surgical patients, and then see how the molecular profiles impacts every stage and every histology. I think just to completely replace stage with just molecular profiling, irrespective of a stage, is, I think, a mistake.
Okay.
So just to finish, we every sentinel lymph node biopsy for everybody in our institution, regardless of grade, histology, and we have some data that'll be published soon. We looked at all the molecular classifications and the risk of micro and macro metastases, and they all have a risk of nodal metastasis. That's not zero.
Irrespective of the molecular stage.
Yes, so even POLE, there was about 5% had micro or macro metastasis in the SLN.
Okay. And last question, so how do you see the future? So do you see any room for development, and maybe on the adjuvant treatment mostly, rather than the surgical?
Yeah, I think there's a lot of room for the future is great. I mean, we just have to learn more. My message, sometimes people think I don't want to do molecular. That's not my message. My message is that it's too premature to be making some of the very strong clinical recommendations currently that I see. I think the future is to further learn more about these cancers. Even within P53, we are seeing other data emerge that even within the P53, there's different alterations that will modify that risk. So I think, and you have to look at by stage too. We looked at our own data for node positive cases. P53 and copy number low did the same in terms of how bad they did. MMR deficient was kind of in the middle, and the poly cases did well. But the problem is all those cases were treated with chemo. So you can't say that because they did well, you should withhold chemo. You'd have to ask that question. So I think the future is great. I think we need to continue to offer next-gen sequencing and molecular characterization of all tumors as much as we can, if resources allow, so that we continue to learn more. I think we have to pause a little bit in how much we're being forced this information in the clinical scenario. Yes, and also for treatment, of course. It'll be very interesting, but I think, I won't say too much, but I think some of the trials that are out right now are probably not the best to do that. They lumped many stages together. I don't see how if I have a poly wild type stage 3 endometrial cancer, I'm not going to treat her or just observe her. But that patient is included in the rainbow study, so stage 3. So, and the problem is that those results will be driven by the majority of cases being low risk cases that probably don't benefit. Yeah. Have very few stage 3 cases. So I think the future is that we continue to learn, continue to do molecular classification on as many cases as we can, continue to properly surgically stage patients, and we have that basis of where we continue to broaden our learning of this disease, and then see if this can affect treatment. The only other areas we're also looking at is can it impact decisions for fertility sparing procedures. Us and others, all very small numbers have looked at this in patients who are MMR deficient, copy number high, which are few. So copy number high is a small number, but they tend not to have as great a response. We also had a poly case that did not have a response in our small series. And then also, can you help with decide who conserves their ovaries? In endometrial cancer, can use molecular classification for that. So there will be a role in some decision making in the future, but we're still a ways from that.
Yes, okay, great. Thank you very much.
You're welcome. Bye.